Good evening, everyone, and welcome to our Contraception and Early Pregnancy Management webinar. My name is Helene. I'm the Workforce Development Officer at Westvic PHN. I'll be your facilitator for this evening. Alongside me also is Jade, who is also a Workforce Development Officer. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. I'm dialing in from Wadawurrung country this evening. We recognise their diversity, resilience and the ongoing place that First Peoples hold in our communities. We pay our respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination for First Nations peoples and organisations. A little bit of housekeeping. You can view the majority of our webinar recordings freely on our PHN Learn YouTube channel. The link to that is on the screen at the moment. Also, could you please see our upcoming events on the screen? You can register for these events via our website. We'll also put a link into the chat for you. A special mention about our upcoming women's health skills training sessions. Practical Implanon NXT training during May in Ararat, Fortune and Ballarat, and IUD training, which will be an expression of interest application with only 5 spots available. Information will be sent out for those shortly. Please make note of our PHN health pathways relating to this topic, and that's on the screen at the moment. You should all be familiar with that. It is a free online resource with localised clinical and referral information for health practitioners. A certificate of attendance will be emailed to all participants. If you could take a moment to check that your full name is displayed accurately on your screen. If not, or you're unsure, just rename yourself or type your first and last name in the chat box. That way we can ensure that you will receive your certificate. This event is being recorded, so if you could keep yourself on mute unless you would like to ask a question during the question and answer time at the end of the formal presentation. We do encourage interactivity and discussion, so please feel free to either type your questions in the chat box or we can take you off mute and you can ask them yourself. Your feedback is important, so if you could take the time to complete the event survey after the webinar, there'll be a link in the chat box to complete this. Our presenter for this evening is Dr. Natasha Daureen Frawley, Clinical Director, Women's and Children's Services, Grampians Health. Welcome, Natasha. I shall now hand over to you.
Thank you, Helene. And thank you, Jade and Naomi, as well, for this opportunity to speak with you tonight. I'm just going to share my screen. So tonight, I've got a very broad topic, actually, and I think it's quite ambitious, but I know that the audience has already worked in this area quite a lot, and so it's more of an update. I'm covering contraception, early pregnancy and early pregnancy termination. I think contraception is a topic that we can't really, and early pregnancy care, we can't really take for granted, especially with what's happened in the USA, as well as even in South Australia. There's always difficulties with maintaining some of these services. So whilst we do have a robust provision of service in Australia and especially in Victoria, we have access to a lot of options for patients. It's not something that we could ever take for granted. I did want to highlight that in the Grampians, it's particularly noted in the 1-800 My Options data, which is a really good website that gives data on access in this area, that we do have a low rate of prescribing and dispensing of early medical abortion compared to the rest of Victoria, particularly areas outside Ballarat. And Grampians region has a low rate of IUD provision, a low rate of Implanon compared to the rest of Victoria. And we also have a high teenage pregnancy rate and birth rate. So I just wanted to highlight the importance of these topics tonight. I wanted to discuss, I'm going to go through the 3 areas that I'm discussing. So first one being contraception. And then at the end, I've got some cases, and then there'll be time for questions as well. So with the contraception, I'm going to go through the 2024 RANZCOG update. RANZCOG did an update with the UK-based Faculty for Sexual Reproductive Health. So it was a combined update across UK and RANZCOG, and it's very comprehensive. It's on the RANZCOG website. They've got the 14 chapters for different areas of discussion in contraception. So tonight I'm going to cover combined hormonal contraception, just some of the updates there, the IUD, progesterone implants and injection, but I'm not going to cover the pregnancy progesterone-only pill or barrier contraception or ring. I just wanted to highlight the typical use and perfect use contraception rates for some of these methods, and then it's highlighted that the ones that we're covering tonight are mostly the ones that have quite good contraception rates when they're used. And the combined hormonal contraception would be the exception. There's a 9% rate of pregnancy with typical use. However, it's a very common contraception, so that's why I wanted to go over that one. So it's one of the most prescribed, combined hormonal contraception is one of the most prescribed medication worldwide, actually, and particularly high in Australia. I was looking at some of the data in preparation for this talk. So we have, it's about 40% of women, 37% when I was reading, were taking the combined hormonal contraception as their form of contraception, and that's reduced from about 47% over about 10 years, but it's quite high compared to worldwide rates. And I think it's an easy. I suppose I do think it's a complicated medication in a way, because there's a lot of factors to consider when you're starting the pill. But I think from a patient perspective, it's often seen to be an easier option. And I suppose the ideal patient starting on the combined hormonal contraception would be, for example, a teenager who's been admitted with pain from ovarian cysts, or potentially an ovarian torsion following a large follicular ovarian cyst, and we're trying to stop that patient getting more ovarian cysts, and they're fairly young and not particularly interested in having an IUD or an implant, progesterone implant. That's probably the ideal patient I'd be starting combined hormonal contraception on, and they're usually medically well. So the RANSCOG guideline update in 2024 did talk about how that it can be started up to day 5 of the cycle without need for additional contraception, and if we started after that time, to use 7 days of alternative contraception. I also wanted to refer you, if you haven't already used these, to the UK medical eligibility criteria for different types of contraception, which I find really useful. So category 1 is defined by the risk to the patient of using contraception with their particular medical problems. So category 1, there's no restriction to use that method of contraception. Category 2, the advantages generally outweigh the disadvantages. Category 3, there are some significant theoretical or proven risks. However, with clinical judgment, potentially referral to a specialist, that still may be the most appropriate use of contraception for that patient. And category 4 represents an unacceptable health risk if that particular contraception is used in that particular condition. So for the combined hormonal contraception, just keeping those UK criteria in mind, they talked about some of the benefits and risks in this updated guideline. And they talked about, as you'd know, it does reduce heavy menstrual bleeding and acne, potentially premenstrual syndrome as well, which obviously that's something that we also use the combined hormonal contraception for in gynecology clinic. They also talked about how it can reduce endometriosis, which we also know, and that's interestingly in the RANSCOG endometriosis guideline, it's considered first line to try and hormonally suppress the endometriosis rather than do a surgical management first up. Then it does talk about reduced ovarian and endometrial cancer, which is also probably quite well known, as well as a reduced risk of colorectal cancer. So they're all pretty common, or sometimes quite significant cancers that can be prevented with use of combined pill. And then talking about some of the risks that we need to think about, it does make a statement that patients should be informed about the risks of combined hormonal contraception before beginning it, in particular the risk of venous thromboembolism, which there is an increased risk. They say it's an absolute risk is low. So in terms of numbers, it's still much lower than the rate of venous thromboembolism for pregnancy, but for a young, healthy patient, getting a venous thromboembolism when they otherwise wouldn't have is still significant. There's also the cardiovascular risks, so the risk of stroke, myocardial infarction, and in particular those with other risk factors such as smoking, past or family history, or high BMI over 30. Those cardiac risk factors and ischemic heart disease risk factors become more significant and potentially mean that the patient shouldn't be using the combined hormonal contraception. Then there is a small risk of breast cancer whilst using the combined hormonal contraception, but that reduces with time after stopping it. they've also quoted a small increased chance of cervical cancer. So it's quite a thorough representation of the combined hormonal contraception benefits and risks. Moving on to the IUD. So like I said, this is a bit of a whirlwind update. I hope that's okay. So with the IUD, we have the two main types, the copper and the levonorgestrel IUDs, of which we now have the 2 doses as well, with the Mirena and the Kylena. And so they're all very, very effective at preventing pregnancy, and they all have reasonably long durations of use. And they do make a comment that we can insert them up to 48 hours postpartum, which we have been doing in select patients at Grampians Health. But if we miss that window up to 48 hours postpartum, then we have to wait 4 weeks due to the risk of perforation, especially if they're breastfeeding, as well as risk of expulsion of the IUD. We've also been doing it at the time of caesarean section with some success, occasionally, and that often needs the strings to be trimmed at a later time, but it can be quite a convenient way of a patient having an IUD, especially if they're having a caesarean section. It might be hard for them to tolerate it postpartum, so we have been offering that. I just wanted to cover the topic. They do cover a lot of topics in the update, but one of the things they mentioned was invisible threads, and I thought that's quite a common thing that we see, I suppose, relatively common. So it just makes the comment that if the threads aren't visible, to be using emergency contraception and alternative contraception until an ultrasound can locate the device. But if it is correctly located on an ultrasound, then the patient can just continue to use it until the time frame that they would otherwise be not using it. And then to remove it would definitely be requiring a referral into the specialist clinics, and we have various methods. We do have an IUD retractor device that's like a little coil that you can use in the rooms. But if that doesn't work, or if the patient's not able to tolerate or consent to that, then we usually use a general anaesthetic to remove it. So moving on to the progesterone-only implant update. So that's also extremely effective at contraception, as we all know. And they don't really recommend using it beyond the time frame recommended, so the 3 years. Whilst it sort of does provide some contraception after that point, it's not enough that it could be considered to be a contraceptive device. They make a comment about enzyme-inducing drugs and how that can particularly impact the progesterone-only implant, and they should have discussion about using alternative medication in that time, alternative contraception. But it's a suitable contraceptive implant for all medical eligibility patients between menarche and age 55. It was quite a broad range of indications. And the conditions where it would not be recommended to use would be breast cancer, any thromboembolism or decompensated cirrhosis, or hepatocellular tumours, or unexplained bleeding. They do report that most patients with dysmenorrhea would have improvement after using the progesterone-only implant. So this is another resource that actually we have a very experienced GP in women's health working at Grampians Health now, Dr. Natalie Korosnikova, and she shared this with me to share tonight. And she's got a broad experience in Queensland in regional and rural abortion care, as well as early pregnancy care. And so she will be helping us at Grampians Health, or she is already helping us with our provision of first trimester abortion care. And so it's really excellent to have her as part of the team. So she shared this with me, which I thought was a really great summary. It's available on the web. I've also got the link to it at the end of the slides. And it's a very easy to read table summary of the different contraception devices, and then with those UK medical eligibility criteria that I put up before, so what patients would be eligible for. So, for example, for breast cancer, current breast cancer, if you go, I don't know if you can see my arrow, but it's like on the left-hand column, like a third of the way down, current breast cancer. So category 1, no restriction, would be the copper IUD, but all the other contraceptive devices are category 4, so not recommended for patients who need contraception. And if on the row below that, breast cancer in the past and no disease for 5 years, Still copper IUDs an option that they can use with no restriction, and all the other options are now category 3, which means that they do have theoretical or proven risks, but those risks may usually outweigh the advantages, but an individualised plan can be made with the patient. So this is the second page of that, with the second page of conditions. So I thought this is a really good reference if anyone's very frequently prescribing contraception. So I'm moving on to the next topic, which is early pregnancy management. I wanted to highlight here the referral pathways to Grampians Health, which you're probably familiar with. We do have 2 early pregnancy clinics a week, Monday and Wednesday afternoon, and the pathway is a referral through gynecology outpatients. And if you write on the referral that you're referring to early pregnancy clinic, that may make it easier for the patient to get to the right spot, but we do have a consultant triaging those appointments. So twice a week we are on the early pregnancy clinic. We know that it's a very common anxiety-inducing symptom and that there is a fair rate of pregnancies ending in miscarriage. So this is just what we do once the patient gets to clinic. So we concentrate more on the ultrasound than the beta HCG levels because they can be quite hard to interpret. I just want to remind you all of the signs on ultrasound and what we're expecting. So just to sort of in the context of trying to diagnose miscarriage or not, and we need to be 100% specific when we're diagnosing a miscarriage because we don't want to inadvertently terminate. So we have very strict guidelines from the ASUM, the Australian Society of Ultrasound in Medicine, on the bottom of this slide. And they're the criteria for ASUM to diagnose a miscarriage on a transvaginal scan. So fetal pole more than 7 millimetres with no fetal heart rate, a gestational sac more than 25 millimetres with no fetal pole, a lack of growth in the fetus or the sac over 7 days, or a previously seen heart rate that is now absent. So they're the criteria on ultrasound that we use to diagnose miscarriage, and it can take a while, which can be hard for patients actually waiting, but I think they appreciate when we explain that we're just trying to be 100% sure before we diagnose a miscarriage. But we see the yolk sac about 5.5 weeks, and that shows us intrauterine pregnancy. And then about 6 weeks, we usually do see an embryo and a heart rate. Usually we see a heart rate about 2 millimetres. So by 7 millimetres, we're really sure if we don't see a heart rate that it is a miscarriage. So in terms of different types of miscarriage, there's the different types here, which you'd be familiar with. So missed miscarriage, incomplete, complete, and inevitable. Inevitable is when there's open cervix. So with our management options that we go through in the clinic, we have the 3 options: expectant, medical, or surgical. And I've copied these from the women's guidelines, which is what we follow as well at Grampians Health Ballarat, Royal Women's. So expectant actually is an option if it's very small products of conception. It might even be the best option if we think it's going to be extremely hard to find at surgery and it's going to be difficult for it to be removed because it's just so small. And it does require a long time frame, up to 6 weeks to resolve, and it can be associated with heavy bleeding and pain. It's not often that patients choose this, but we wouldn't really gear them towards it except if there's very small products of conception, such as less than 15 millimetres size of the sac. Expectant follow-up, we do follow up in the clinic by telephone or face-to-face in the early pregnancy clinic, and we do ask them to follow up with their GP within 4 to 6 weeks. The medical management of early miscarriage has a reasonably high success, and we have recently started adding mifepristone to this regime to increase the success. So it goes from about 70% success up to 90% if we use mifepristone as well, similar to what we would use in a first trimester termination. And this is the best option if it's about 9 weeks or less miscarriage, avoiding surgical risks, but some patients would prefer the surgery. So we have a clear discussion with the patient and then have shared decision making. With medical, we prescribe similar to the MS2 step, so the mifepristone, then misoprostol 800, and then followed by a dose of 400 4 hours later with analgesia and antiemetics. And this would all be done through the gynecology EPAS clinic. And we do follow up by phone as well, so similar to the expectant. Surgical option is recommended if they're heavily bleeding or unstable, or it's a patient's preference, or if it's a pregnancy that's over 9 weeks size. and it's almost 100% success. I usually quote a 1 to 5% chance of repeat curette for retained products. So these are some of the common side effects of the surgery that are quoted in the UK RCOG guideline. So it's very common for them to have bleeding for up to 2 weeks. Infection-wise, we do give antibiotics. There's a small chance of having laparoscopy and an even smaller chance of needing a laparotomy with this procedure because of perforation, and intrauterine adhesions would be the other side effect. So this is sort of a summary of where we direct patients with a miscarriage by the size of the gestational sac. So under 15 millimetres, usually expectant, over 30 to 35, usually surgery, and in between is usually either option's reasonable. If they've failed a previous one, we usually go to surgery. In terms of special mentions or special further topics on this, so when the pregnancy is unsighted, we have to assume it's an ectopic or pregnancy of unknown location. And so we do follow up the patients with beta HCG tracking to 0, and we discuss the care through the consultant on call. In terms of the anti-D guidelines, and so we give that for any procedure, so any dilatation and curettage. We don't need to give that for miscarriage that's spontaneous or medical miscarriage. Up to 10 weeks, we don't give them the anti-D. So in terms of early pregnancy, I think the times to escalate would be for the threatened miscarriage or the diagnosis of miscarriage on scan. In terms of recurrent miscarriage, which is defined as 3 or more first trimester miscarriages, so there's actually not that many further investigations that we do. It is a lot done on history. This is the ESHRE guideline, which is the European Society of Human Reproductive Care. And so for the third miscarriage, we would do histopath and send the karyotype of the products and consider parental karyotype if the products had an abnormal karyotype, the products of conception. We always do antiphospholipid antibodies. We do thyroid antibodies, including anti-TPO antibodies, and a 3D ultrasound for uterine abnormalities, looking for things like a septate uterus or bicornuate uterus or a polyp that could be contributing. But we don't routinely do any other tests unless it's indicated on history. So we don't do diabetes screen or other testing unless indicated. So the management of this, so the patients do benefit from a continuity of care model, and we follow them up in general gynae clinic, occasionally offer them care for Royal Women's at their recurrent miscarriage clinic, or try and emulate something similar to what Royal Women's do here, which is quite difficult, but patients do often want their care close to home, which is very reasonable. So I just want to share this recurrent miscarriage guideline, and just this is the one that we go to when we have a patient with recurrent miscarriage, to the European Society guideline. Also, another aspect of this topic is the molar pregnancy, which is also very, very rare, but when it happens, this is the patient information from Royal Women's, and with the molar pregnancy, we describe it as sort of a abnormal pregnancy growth that potentially is like a pre-cancer, and so it does require follow-up, occasionally can turn into a persistent disease, and even very rarely can turn into a gestational trophoblastic cancer. So it's 1 in 1,000 pregnancies. Once we get the pathology back, we do refer the patients to Royal Women's for centralised tracking, and then the patients have pathology slips mailed to them to have centralised tracking until they return negative beta HCGs. Depending on the original histology, they may have quite a short follow-up, or they may have a longer follow-up, and they may need further treatment occasionally, such as chemotherapy. We discussed with them they'll need contraception during this time, and for future births or pregnancies, they'll need their placenta sent for histopath, because it can occur in a future birth, even with a term pregnancy. So finally, my third topic was termination of early pregnancy. And so again, referring to the RANZCOG guideline on this topic, just to highlight that this is from the Royal Australian College of GP, Australian Family Practitioner 2016 study that showed that this is the contraception use of patients at the time of an unintended pregnancy, and more than 60% of patients were using a form of contraception, most commonly the combined pill or the condoms. So with early pregnancy abortion, there's the different techniques. So dilatation and curettage is usually done up to 14 weeks. Dilatation and evacuation is done after 12 to 14 weeks. And in our centre, we usually refer them to Melbourne for this. And then early medical abortion is done through our hospital, and it can be done now as well through any GP who feels comfortable to do this. It doesn't require any further authorisation, as I understand now. So I'm going to concentrate a bit on the early medical abortion. So at Grampians Health, we've got clinic at least once a week. Now we're increasing to twice a week. So Wednesday and Friday, we're going to have early medical abortion clinics. And we offer mostly face-to-face. However, there is some options for telehealth as well, trying to capture patients who don't necessarily live in Ballarat and who require a telehealth. We offer it up to 10 plus 0 weeks. So the MS2 step on the PBS, as I understand, is up to 9 plus 0 weeks, but Grampians Health does fund it up to 10 plus 0 weeks. And the data from a safety profile is that it's very safe up to 10 plus 0 weeks. And we, in Grampians Health, our process is that we provide the abortion. We don't really provide the other care around that decision. So patients are referred to 1-800 My Option for counselling, and they can access counselling through that service. And then if they've decided they're going to have the abortion, then they come to the clinic. They will have a discussion with the doctor on the day and have consent, but there's limited counselling provided in that clinic. And then we don't test for hemoglobin. We do routinely test for rhesus status, but we don't actually need to. But we often do test it, I think, as a carryover from previous. We probably need to update that, actually. And we do test for infection as well and treat that if needed. We also test for cervical screening if that's due, and then and follow this up. So I wanted to, I suppose, share with the audience our service, and that if people were prescribing early medical abortion in Grampians, and then the patient had retained products or they wanted a question about the patient's care, we're very happy to see any patients who need follow-up after having an early medical abortion in the community. And we also happy to support anyone who wants to upskill in this area or wants to spend some time in the clinic with one of our doctors, so who do this care, so that they could take it back to the community. So this is something that's very important, to be able to allow patients to get this care close to home. So when we're writing it on the medication, we just write MS. You can write MS2 step as your prescription, and then I'll often spell out the mifepristone 200 and the misoprostol. We actually also give another dose of misoprostol, 400, 6 hours after that first dose of misoprostol. And again, this is something that we had on our original protocol, and we've just kept that going because it works. We've reviewed our outcomes, and they're really got a low rate of retained products. And so we've kept going with that extra dose of misoprostol, but that's not necessary if you're doing it in the community. It's not technically on the MS2 step protocol. Then we follow them up within a couple of weeks to check serum or urine beta-HCG. We also give analgesia and antiemetics. Then in terms of offering the surgical treatment for abortion, we do have a list here once a fortnight in Ballarat. We've also, Stall Hospital's been renovated, but it's opening on the 1st of April, on April Fool's Day. And so far they're on time to open. And there's 3 stall lists a month from the gynecology unit over 3 weeks out of 4, and they're all going to offer a surgical termination service in Stawell. So that will be offered in Ballarat and Stawell. We also have a GP in the community who's put up their hand to go to Horsham and provide some surgical service in Horsham, which is excellent. We're still getting that off the ground, but that's hopefully on the horizon for 2025 that there will be Horsham surgical termination of pregnancy as well. We're currently offering it up to 12 weeks. Over 12 weeks, it does require some further specialised training, and at this point, we don't have that locally in a consistent way. We have it ad hoc, but we can consistently provide surgical abortion up to 12 weeks, and between 12 and 14 weeks, it depends on the skills at the time. And then over 12 weeks and definitely over 14 weeks, we refer patients elsewhere for a surgical termination of pregnancy, and that's usually Melbourne. Occasionally, we refer to Kyneton or other providers regionally who are doing up to 14 weeks, sometimes Geelong as well. We do it always under a general anaesthetic. We don't do conscious or deep sedation. And yeah, we have a very good rate of this procedure working and patients having a good outcome. For contraception, we always have that discussion with the patient, share decision-making, and offer them all the options. We do encourage a long-acting reversible contraception if the patient consents to that, and we offer all those options at the time of the abortion. So we would insert an IUD or an implant during the anaesthetic if the patient was going down those options. But we also, if patients choose to have condoms or the pill after they've had an informed discussion, that's fine. So we have that good discussion with the patient. If there's an incomplete abortion, which this is usually in the setting of vaginal bleeding, ultrasound's difficult, actually. It can be hard to interpret, but we generally will do one just to try and quantify it. And options would be repeat surgery or misoprostol. Often the repeat surgery is really difficult because it's very minimal retained products. It's quite hard to capture. So if possible, misoprostol is good. Unless the patient's heavily bleeding, then they may need surgery. So these are those links I said before that I would share. So one of them is on the UK criteria, the top one, and the second one is on the USA summary of the UK criteria, which I thought was really good. So these are the cases. So case number one, Alexandra is a 38-year-old gravida 3 para 3 who is 6 weeks postpartum and wanting contraception. Her family is complete. Medically, she has been on Clexane through the pregnancy and postpartum because she's had a previous DVT pulmonary embolism, and she's otherwise well with a normal blood pressure and BMI. With that case, I'll just go back to that. Hopefully that's still working. So this woman's finished her family. I thought she's obviously wanting something like that's going to have a very high rate of contraception and a low failure rate. So her options would be things like a Mirena and Implanon are still good options, even though she's finished her family, because they actually do have such high success rates. It's higher than a tubal ligation or self-injectomy. So the LARC, the Mirena or Implanon, would be one option for her. The other option would be a self-injectomy, so we've moved away from tubal ligation. We do more self-injectomies now because of the reduction in ovarian cancer. But I suppose the other thing to consider with self-injectomy is her surgical risk of having a DVT due to having pelvic surgery. And then the final option, of course, would be a vasectomy, which is probably going to be the best option really for her health. And so the vasectomy's also got the lowest rate of a future pregnancy, but we'd have that discussion with the patient. Next case study I had was Priya, 39-year-old G2P1, who's 4 weeks post her period with a positive home pregnancy test. She's attended just with some mild unilateral pain because she only come because she's planning to go overseas for a holiday in 2 days, and she thought she'd better get checked out. So what would be our differential and what would be our next steps? Oh, yeah, I saw actually last ectopic. Thank you. That's the red flag that we want to exclude. Ovarian pathology, yes. So something like corpus luteum, ruptured corpus luteum, or just a period pain, yes. and potentially could be like an unrelated pain separate to the pregnancy, like period pain or appendicitis even, or colitis. So our next steps would be urgent pelvic ultrasound, yes. So we want to site this pregnancy and see if we can see a yolk sac in the uterus, or if not, if it's a pregnancy of unknown location. Yeah, beta HCG, yep. Thank you. So we do some investigations, and we probably also get quite a bit on the history, on the severity of the pain, what analgesia she's used, whether she's had any bleeding, and then her abdomen, whether it's soft or rigid, any guarding. Potentially could do a speculum and bimanual, but it may not be diagnostic. With the bloods, yeah, FBE and a beta HCG. Pelvic ultrasound needs to be today, given that she's going overseas, and she may need to delay her trip, or we may need to have that discussion with her depending on what we find in that. So then the third case is Lauren, who's a 25-year-old nulliparous woman wanting contraception. You've discussed her options and she wants a Mirena or Implanon. What are your considerations, and would it change if she lived remotely? So when someone's wanting a Mirena or Implanon as their presenting complaint or presenting request, sorry, what do we want to know before going ahead with that? So it's things like if she's sexually active currently, how many partners, what contraception she's used in the past and any side effects, ruling out pregnancy, considering STIs past and current, cervical smear history, and then in terms of insertion, what time of the cycle would we want to be inserting a Mirena? Yeah, pregnancy. Day 1 to 5, thank you. So we'd be inserting it early in the menstrual cycle, and then having education about need to protect for STIs. In terms of being remote, is that going to change anything? Say she lived in Horsham and it was a telehealth. We're thinking potentially, not changing the discussion. The discussion's still the same, but in terms of insertion, where's she going to have that? She's going to have, will she need transportation during or after the procedure if she had a general anaesthetic to insert it? Okay, excellent. Well, I think I've whizzed through that, hopefully not too quickly. I'll stop sharing. So going over to questions, if anyone has any. Or comments if there's further tips that you want to discuss with the group.
Thanks, Natasha. There is a question. Can Mirena be inserted any time if pregnancy excluded?
Yes, it can be. So I think that there's always a risk that they will get pregnant the next 7 days. So they should be using an alternative contraception for the next 7 days after the Mirena inserted, like condoms as well. But if we've excluded pregnancy, I like to exclude it on history as well as either a urine or serum beta HCG.
Could cylinder be used for contraception with prior HX DVT?
So it's category 2 on the UK medical eligibility criteria, meaning advantages generally outweigh theoretical or proven risks. So my understanding is I feel pretty comfortable using it, thinking that they're not going to get a DVT pulmonary embolism, but there's still a theoretical risk that we probably need to discuss with the patient and just make sure they're aware of that and having informed consent with using Slinder in the setting of a previous DVT pulmonary embolus. That's my feeling. Other people might have different opinions. I just see the question about early medical abortion in the setting of not seeing a yolk sac. So I'm happy to answer that.
Thank you.
So it's a good question. Actually, we don't do it in Grampians Health Ballarat. We do require a yolk sac to be visible. And that is, again, the RANSCOG guideline says that you can just take a history from people. You don't even need to do an ultrasound before doing an early medical abortion if it's a low risk of an ectopic. However, because we're servicing the Grampians and we do have people who don't live very close to a hospital that can provide surgical services for an emergency ectopic, we take that into consideration. And so we do wait for a yolk sac to be visible before we prescribe an early medical abortion, even people who live in Ballarat, so that we just feel more confident that we know what we're dealing with. And that's something that may change over the next few years as more data becomes available about the safety of prescribing early medical abortion without a visible yolk sac.
I'll just add to that, Natasha, if that's all right. In Queensland Health Guidelines also suggest a yolk sac. So they are the same as Victorian guidelines for termination.
Do you think they have more bleeding when they're further along? Oh, waiting for the yolk sac, you mean, as well? Natalie, do you want to comment on that one?
So was it bleeding regarding waiting later on in gestational age to provide the medical termination? Is that what the question was about?
Yeah, I think so.
Oh, it varies. Yes, yeah. Thank you. It really does vary. Some people, and when I counsel patients regarding medical terminations, I say some people have very limited bleeding, and some people can have quite significant bleeding. We can never say who it will be, but definitely, especially if they're having a termination with twins, that not that it happens frequently, but that tends to carry a higher rate of bleeding just due to the volume that's inside with the two babies in there. So I guess theoretically, probably yes is the short answer, but some people you see don't experience a lot of bleeding at all and some people do. So it is individualized as well.
No more comments. Any closing remarks from you, Natasha, or any of the others?
I just want to say thanks for the opportunity. I hope, please reach out if you have any questions about the referral pathways or any suggestions there. That's a very important few topics and it's good to be able to talk about it. Thank you.
Thank you. And thanks for everyone for attending and for your contribution this evening. That was a great presentation. Thank you so much. We learned heaps tonight. And please don't forget to contact Natasha if you've got any further queries. I'll now end the webinar and thank you everyone for attending, especially Natasha for presenting. Thank you.